So, what exactly happens inside your body when your resting blood pressure sneaks past that critical 130/80 mark? It's a high-stakes scenario, honestly. We're talking about a silent killer lurking right inside your vessels, doing severe damage without you even feeling a thing. Now, before we get started, do yourself a favor and turn on those English subtitles so you don't miss a single detail of this fast-paced whiteboard masterclass.
Welcome to This Explainer. I'm your host, and today we are totally skipping those boring, drawn-out textbook introductions. We're diving straight into the hardcore pharmacology of antihypertensives like a sharp knife through warm butter. You ready? Let's get right into it.
Section 1. Meet the silent killer. Essential hypertension is completely asymptomatic for like 90% of people, right up until major end organ damage actually happens. Imagine I'm grabbing a marker and drawing some blood vessels out on a whiteboard for you right now to explain why. See, your blood pressure heavily depends on two main things, your arteriolar resistance and your venous capacitance. In hypertension, increased smooth muscle tone in those little arterioles strictly restricts blood flow. So this increased resistance, combined with a low venous capacitance, basically forces your heart to work overtime against a massive load. And that significantly raises your risk of irreversible damage, like a stroke or heart failure. It is serious stuff.
Section 2. Classifying high blood pressure.
Okay, grab your mental markers here because we need to map out the specific numbers we use to actually diagnose this villain. Normal blood pressure is strictly less than 120 systolic and less than 80 diastolic. But if you cross into that 130 to 139 systolic range, boom, you are in stage 1 hypertension. But here is the absolutely crucial catch. An actual diagnosis requires resting measurements on multiple occasions. That means you can't just take a reading right after fighting traffic to get to the clinic, and absolutely no coffee or smoking allowed right before the test either, or you'll totally skew the results.
Section 3. Mechanisms of blood pressure.
Now it's time to map out the battlefield. Picture me drawing some flow arrows on the board to trace the renin-angiotensin-aldosterone system, or the RAS pathway. Step 1, a drop in pressure or a sympathetic drive tells your kidney to release renin. Step 2, that renin helps form angiotensin II, which is a brutally potent vasoconstrictor. Step 3, this triggers the release of aldosterone. And finally, step 4, aldosterone tells your kidneys to retain sodium and water. This whole cascade drastically increases your blood volume and therefore your blood pressure. A super quick mnemonic to remember the flow, just think of the letters RAAS. Renin activates angiotensin, which activates aldosterone, causing sodium retention.
The second mechanism you need to know is the sympathetic nervous system and the barrel reflexes. Think of this as your classic fight-or-flight response. Like, imagine you're literally running from a tiger. Your beta-1 receptors ramp up your heart rate and cardiac output. Meanwhile, your alpha-1 receptors constrict your smooth muscle, massively increasing vascular resistance. And those same beta-1 receptors hanging out in your kidney, they stimulate even more renin release. It's a massive, brilliantly coordinated pressure spike designed to keep you alive in an emergency, but chronic activation of this system is deadly.
Section 4. Antihypertensive drug classifications.
All right, now that we know the enemy, let's enthusiastically review our pharmacologic arsenal to fight back. First up, and imagine this highlighted in bright, high-contrast neon colors on our board, we have the diuretics. These are often our true first-line agents, drugs like hydrochlorothiazide or furosemide. They lower blood pressure by simply reducing your overall blood volume. How? Well, they literally tell your kidneys to pee out the pressure by excreting excess sodium and water. Less volume in the pipes simply means less pressure against the walls.
Next up, a classic pharmacology comparison, ACE inhibitors versus ARBs. The crucial point here is understanding how they target different steps of that perilous RAS pathway we just mapped out. On one hand, we have ACE inhibitors, which pretty much always end in pril, like captopril and lisinopril. They stop the formation of angiotensin II, but as a side effect, they increase a peptide called bradykinin. On the other hand, ARBs, which end in sartan, like losartan and valsartan, block the angiotensin II receptors directly. This entirely bypasses that whole bradykinin issue.
Let's bounce over to calcium channel blockers, or CCBs. We generally group these into two camps. First, the dihydropyridines, which end in dipine, like amlodipine. These are fantastic for isolated systolic hypertension and for elderly patients, primarily because they cause absolutely zero metabolic disturbances to your glucose or lipids. Then, we have the non-dihydropyridines, like verapamil and diltiazem. A quick memory trick for you, verapamil acts on the ventricles. It affects both the vascular smooth muscle and the heart itself.
Moving on, we have the sympathetic blockers. Beta blockers like metoprolol bring down your cardiac output and that kidney renin release. Alpha blockers like prazosin relieve that smooth muscle tone in your arteries and veins. And then you've got the heavy hitters, alpha/beta blockers like carvedilol. These act as a powerful 1-2 punch against the sympathetic nervous system by blocking alpha-1, beta-1, and beta-2 receptors all at the exact same time.
All right, quick quiz time for the pros out there. Which of these medications causes an infamous, persistent dry cough? Keep actively guessing in your head while we bridge the gap into our next crucial topic.
Section 5. Side effects and contraindications. Let's look at the friendly fire of our medical arsenal, because as any good pharmacologist knows, every medication has a trade-off. The answer to our quiz? It's ACE inhibitors. Remember how we just mentioned they boost bradykinin? Well, bradykinin is a fantastic vasodilator, but unfortunately, accumulating too much of it triggers that dreaded, ticklish, persistent dry cough. It even carries a rare but real risk of life-threatening swelling called angioedema.
Now, beta blockers come with their own specific baggage. They can cause bradycardia, severe fatigue, insomnia, and even sexual dysfunction. But listen, I need to give a very severe warning right here. Prescribing a non-selective beta blocker to a patient with asthma is an absolute contraindication. Blocking those beta-2 receptors will cause severe bronchoconstriction and massively worsen their asthma. It is a huge red flag.
And hey, we absolutely cannot forget what I like to call the doofus mistake. If you have a patient taking the central alpha-2 agonist clonidine, never ever abruptly stop the medication. Seriously, stopping it suddenly will trigger a massive, highly dangerous rebound hypertensive crisis. You always have to taper it slowly. Just don't be that doofus.
Section 6. The treatment algorithm.
Okay, let's bring all these mechanisms and meds together and map out our ultimate clinical battle plan. First, we have to know our target. If the patient is 60 years old or older, the treatment guideline goal is generally to get their blood pressure below 150/90. But if they are under 60, or if they have concomitant diseases like diabetes or chronic kidney disease, we need to be way more aggressive. For them, the goal drops to strictly less than 140/90. If they aren't hitting that goal, we roll out the strategic escalation playbook. Step 1 is to initiate monotherapy with a thiazide, an ACE inhibitor, an ARB, or a CCB. If that doesn't do the trick, Step 2 gives you some options. Step 2A is to simply increase the dose of that first drug. Step 2B is to add a second medication before you even reach the max dose of the first. Or, Step 2C, if their pressure is just dangerously high right out of the gate, you completely bypass monotherapy and start with 2 different medication classes right away. But listen closely to this next part. Don't be a confused neuron. A little Easter egg shout out to all the channel fans out there. The absolute golden rule of this entire escalation strategy is to never combine an ACE inhibitor with an ARB. Since they work on overlapping parts of that exact same ROS pathway we learned earlier, combining them doesn't give you magically better blood pressure control. No, it just dangerously compounds their toxicities. Just don't do it. Before we wrap this up, I absolutely must remind you of the true cornerstone of management. Before any prescriptions are written, before a single pill is popped, lifestyle modifications are the real first-line therapy. Weight reduction, a low-sodium diet, regular exercise, and obviously stopping smoking. These habits not only lower a patient's baseline pressure naturally, but they actually enhance the efficacy of every single drug we just discussed today. So we've explored the hidden dangers, the complex pathways, and the incredibly powerful pharmacology we use to treat essential hypertension. But remember the craziest stat of all? 90% of cases have no identifiable cause and absolutely 0 symptoms until it is literally too late. Which leaves me with one final provocative question for you. What is your body's silent baseline reading right now? Go grab a blood pressure cuff, find out, and keep learning. Thanks for joining me on this explainer.